Okay. If there's no further question, maybe we should go to the next speaker. Prof. Liu, will you introduce the next speaker? Okay. Liu, will you introduce the next speaker?
Yes, the next speaker is Dr. Wang Pei. Wang Pei is also from Beijing. Unfortunately, I don't have his curriculum vitae with me right now. Nevertheless, I think I'll pass the stage to him, Dr. Wang Pei.
好的，非常高兴哈，今天有这个机会跟。
I'm so happy to have this opportunity. So I see we have experts from Malaysia, and we have domestic colleagues to talk about the comparison between tri-wedge balloon and high pressure balloon. So I'm from Zhengzhou. Zhengzhou is located in the central part of China. It's a province with a larger population, and Zhengzhou is the capital of this province. So today's topic would be the comparison between tri-wedge balloon and high pressure balloon. As for the AVF, that is the venous system issue, we could see is the eccentric at the intimal hyperplasia, and for some cases there are some valve stenosis and the external pressure, and the characteristic would be the angle from the anastomosis to the artery is large. So for some special balloons, it's difficult to pass. And the difference between this and the artery system is that we need puncture, and puncture is an important factor for recurrence, so the recurrence rate is high. So when we use the balloon for the AVF, we want to reach three purposes. The first is that we could reach the lesion. So we could open the lesion, and we could suppress its recurrence. In order to reach the lesion, there are several aspects, for example, traceability, pushability, and the passing capability. So we all know this. In order to open the lesion, and for use it in the AVF, that is non-compliant high pressure balloon. Generally speaking, when we use it in the AVF, the burst pressure is nearly 20. Is even higher pressure could open the lesion. Well, of course, for some balloons with special design, like the tri-wedge, like the tri-wedge is one of the cutting balloons. To suppress the recurrence, mainly rely on the use of the DCB. For such so in China, it hasn't been approved yet. So for such a balloon, this is the tri-wedge. We could see the indications, including the peripheral arteries and the AVF stenosis lesion. Therefore, this balloon we see is a triangle-shaped guide wire that is not a circle, but it's a triangle. So when we dilate, the pressure is concentrated to the point contacting the vessel. So by doing that, we could improve the local dilation power. So it functions like cutting balloon. The tri-wedge balloon, this is over-the-wire design. The three metal wires are at the surface of the balloon. So there are two systems, so 0.018 and 0.035 And there are many options available from 3 to 8 millimeters. As for the product design, these are the characteristics. So with lower pressure to dilate the stenosis is a high pressure non-compliant balloon. This is the guide wire rather than the razor blade, so the passing capability is better. So with all these features, we hope it could extend the survivorship of the opened lesion. The traceability and the passing are good, and the apposition is better. We see compared with the angiosculpt balloon, the curve passing capability is better. Maybe it functions similar to the high pressure balloon. So when it opens the lesion, the tip of the triangle-shaped guide wire is released stronger. It functions like the cutting balloon. So for refractory lesion, it is supposed to have a better opening effect. Therefore, we see the burst pressure is relatively higher. It could reach 20 for 7 and 8 it's 16. And for the high pressure non-compliant balloon, plus comparison with the guide wire, the opening capability is better. Let's have two cases. So in China, this balloon has not been launched yet. So we participate in their pre-marketing clinical study. We've enrolled about 40 cases so 1-to-1 for tri-wedge and high pressure balloon. So we have 20 cases using tri-wedge. So we have two cases here. The first case is a female 31 years old. She was admitted in March 2021. So the chief complaint was the volume of the internal fistula decreased for 2 weeks, and the primary lesion was ANCA-related vasculitis. So 6 months before the intervention, so that was the first dilation. The volume is 339 millimeters, the humeral artery. So the treatment would be we use a 6 millimeter sheath, and we choose a 6 millimeter by 40 millimeter tri-wedge balloon from the distal end of the radial artery. We could see. So we use 6 ATM. It was like that, and like that at 8 ATM, and it was fully dilated at 10 ATM. Although we didn't dilate the lesion, the pressure we used was low. It was relatively lower pressure, and we could dilate the lesion. After the treatment, we see the treatment image looks beautiful, very good looking, and no significant recoil of the lumen, and the humeral artery blood volume was 900 ml per minute. Now it has been 8 months, and the fistula has been good. For the second case, also female, 51 years old, she was admitted in March 2021. Also, the chief complaint was the insufficient flow of the fistula for 2 weeks. And she received this intervention treatment. We could see the lesion was a tortuous lesion. The angle, there are 2 major curves. Actually, there are 3 major curves. The volume of the humeral artery was 4 and 34 ml per minute. So the first pass was a retrograde. And after we entered, the guide wire could not pass the lesion. And because it cannot pass, so at the humeral artery, we did a puncture, and we didn't use the sheath. We didn't enter the artery sheath. We just enter the guide wire after passing the lesion. From the 6F sheath, we put out the guide wire and we established the working channel. After establishing the working channel, we still use the retrograde tri-wedge balloon. We send the tri-wedge balloon to the lesion. To dilate, we used a 7 by 40 millimeter balloon. You could see the angle is a large angle. The traceability and the passing capability of the balloon is quite good. The angle is far greater than the cutting balloon or the conquest balloon in terms of the traceability. During the dilatation, we could see it was opened at 1080 ATM, and the lesion was totally opened. After the treatment, after the dilation, with the humeral artery caster, we made a run. So the dilation effects were good. The stenosis was relieved. The blood volume was good. It was 1,050 ml per mil, and up to now it has been 8 months. The internal fistula was in good function. And for the last dilation, and she used it for 3 months. So from December 2020 to March 2021, so therefore she used the channel for 3 months. But for this time, she has been using the channel for 8 months, so it has been good. So finally, take-home message: the tri-wedge balloon, it has a relatively lower dilation pressure, and it's about 8 to 10 ATM. So in our 20 cases, it's between 8 to 10 ATMs. And the benefits would be it's better in terms of pain. And in theory, it's a high pressure non-compliant balloon. So for other refractory stenosis lesions, it has better opening capability, and it has excellent traceability and capability of passing the lesion. And for its long-term patency, we may need more clinical studies to see. That's the end of my presentation. Thank you.
Thank you, Dr. Pei. Thank you. Any questions? Anyone has any questions?
Dr. Wang Pei, I just want to find out from you. If you have used, let's say, a 5 mm balloon, and then, after opening up the narrowing, can you still use the same kind of a balloon to upgrade to, say, a 6 mm balloon? Using the same scoring balloon, now you use a larger size scoring balloon, or would you go back to just other balloon?
So you mean for one treatment, or just one lesion with 2 different treatments? What you mean? Which scenario?
One lesion with 2 different treatments. Meaning that if you open up using a smaller balloon, you can't open it up totally. Can you then use another same scoring balloon to open up?
For me, I would choose the same sized cutting balloon.
Okay, that's fine. And I want to find out from you, you said when you need to cross a stenosis, crossing a stenosis, does the length of balloon matter to you? Would you use the shortest length, or would you then?
这个来讲的话，我们主要是根
So
据
actually, this is dependent on the length of the lesion. Well, for the crossability, it has no significant relevance with the length of the balloon, because for the short balloon, if we have the high angulation in the vessel, so I'm going to be concerned about the damages to the two ends of the vessel. So maybe for the anastomosis side, if we use the longer balloons, then it may have some advantages. But what we hope is that for the balloon itself, the compliance can be good, because for the other balloons, they're gonna be very straight. It's gonna be very hard on the vessel, so which may also cause damages.
Okay, all right.
Can I ask a question? Would you cross across an anastomotic point with your scoring balloon?
So
among all the lesions that we have treated, we have used the scoring or cutting balloon in the anastomosis, and we use the Boston Scientific DCB in combination. So if we found that the angulation is good, then we can use the scoring balloon.
I've got a, hi Haris here from Malaysia. I got a technical question. Basically, let's say if you have BCF with the juxta-anastomosis stenosis, and then you try to do the banana, go across the wire, and then the wire have to go into the proximal brachial artery. But we've tried many times because of the angulation, maybe the anastomosis was too angulated. Sometimes in the RCF we see that you cannot go into the proximal. So do you just park your wire distal, let's say distal radial or distal to the anastomosis, and then just balloon it with the tri-wedge, or you still maybe, you know, let's say if the RCF, you puncture it proximally in the radial artery and then try to, you know, get the C that you want, then you balloon with the tri-wedge.
Actually, for us, we have different scenarios. For the first case, we use the distal part of the radial artery to have the establishment of the access. We get the wire in and do the dilation. For the second case, because the distal part of the radial artery is very small, that's why we have the access from the brachial artery. But for this access, we will just use the gap wire to cross anastomosis to get into the vein. From the outflow of the vein, we're gonna introduce the sheath, and also to pull it out from the sheath. For the balloon, we use the retrograde access to get to the lesion.
How about the other speakers? Any thought about this as well?
Actually, interestingly, I have for the second case last week, exactly a week ago, I have a similar case like the second case. In fact, the narrow is even more narrow. It's almost occluded really. It took a while to pass the guide wire across the lesion. It took a long time, in fact. But once it passed over, I thought, because it's a 018 wire, I thought there's no way the balloon will go through, you know. But surprisingly, actually, a size 5 balloon actually managed to go through tri-wedge, and we actually opened up across the lesion. There's no issue. I mean, I have done it a lot of times across the lesion. You balloon it out. There's no problem with that. And the thing is, I was very surprised that it actually can go through the anastomosis over 018 wire. But it's not so stable. But yeah, it was really good. The other thing about using two balloon, which Prof Lee was mentioning, I find that using two balloons. I mean, for most of my cases, I actually use at least one or two balloon, at least two balloon. Usually I start with a smaller one and then use a bigger one. In fact, in fact, today only I have two cases. Also, the first one I use a size six tri wedge. You know, so with the tri wedge you can actually open up and then cut through all the fibrous tissue and all that, and it opened up very nicely with a size 6 balloon. I would have thought maybe I'll leave it alone, but then I thought, well, I mean, might as well try a size 7, but I won't use the same because of the cost. I use a plain balloon for size 7. And when I inflate the size 7 balloon, you can see actually there's still a lot of residual stenosis. When you open up, only you can see it. And but the good thing is it actually opens up very easily. You don't even need to go very high. It actually opens up. But I think because the first balloon with size 6 it actually cut through all the fibrous tissue, so there's hardly any recoil. So one of the things which you can use is use tri-wedge as the first balloon, but of course you can use as a second balloon, but the cost may be high. You can just use a plain balloon, bigger one for the next one.
Do you think it's got to do? I mean, you're talking about getting the wire into the proximal radial artery.
Yeah.
Is that the main concern? I mean,
Yeah.
what's your workhorse catheters that you use actually for crossing, let's say RCF? I'm sure the most trouble is in the RCF rather than
Yes,
the
yes.
Yes.
I mean, normally we will try with the burn catheter first. If cannot, then Cobra, and then if really cannot, then I don't know, most of the time we can get away with the Cobra lah, but sometimes if we really cannot, then I will just go down to 018 system and then try. If most of the time can, but sometime if I really want to do the C, I mean the banana, then I will just puncture the brachial artery retrogradely, just use a micro puncture and then just get from the brachial artery go into the cephalic vein lah, and then do a C and then rendezvous, and then you can actually introduce the balloon retrogradely to the venous puncture, and then you can go to the artery proximally. Because I'm worried if we balloon it across into the distal radial, sometimes you cannot get that tamponade effect. Let's say if it's rupture, because you don't have the proximal control. So that's my concern when we don't do the C. So that's why I'm asking whether, I mean, is it really necessary? I mean, is it safer with this tri-wedge if we can just no need to do C, just just plug our wire into the distal part and then just balloon it?
Actually, one of the options is nowadays I like to go if there's enough length of the distal radial artery, I will usually go through the distal radial, use a very low profile, because now tri-wedge has a very low profile balloon for 018 wire, so you can actually balloon, like a Y, you balloon at the anastomosis and then you can go up again and balloon the juxta anastomotic area. Instead of crossing it, you go distal to the distal radial artery.
So it's like an S lah. I mean, basically
like a Y, You go, you balloon across the anastomosis, and then you get the wire up into the vein, and you juxta anastomotic region, and you balloon that one also.
Okay, understand.
So, because sometimes it's so difficult to cross the anastomosis.
Yeah.
So I do that. Actually, the results are actually very good. You get very good results. But then the thing is, you need a very low profile balloon, which I think only recently, few months ago, only they brought in the low profile tri-wedge.
I find sometimes, I'm not sure whether you guys have come across this. I don't know, Dr. Wang, do you have this kind of cases where fistula, which is site to site anastomosis, which we find sometimes Very few of our colleagues do that, but do you find difficulties with that side-to-side anastomotic fistulas?
Uh, 您的意思是就是两
So
个
you mean that yeah,
塞不吻合，然后这个角度很小。
yes. So side to side anastomosis with very small angulation. So for our fistula, we normally don't do those accesses, but for the end to side anastomosis, sometimes we would also have big angulation cases. They would also have big angulation. Sometimes if we want to pass the wire, it's going to be very difficult. Therefore, normally we would check the distal part of the artery. If the distal artery is good enough with good size, then we will access from the distal artery, but we need to check the size or the diameter of the artery and the vessel, and then make the decision.
Dr. Wang, do you have any experience doing the using tri-wedge in graft? Let's say AV graft with the outflow stenosis and the anastomosis?
Well, we don't use tri-wedge in the AVG anastomosis. Right now, it's not marketed in China. So right now in China's clinical trial, we only include AVF. We don't have AVG in the clinical trial.
Oh, okay. How about Dr. Lin?
Yeah. I use it a lot of times. In fact, 2 days ago, I just used
For the AVG, yeah?
AVG. Yeah.
How do you find it?
It's pretty much the same. I find it, the recoil, AVG, the AVG vein graft junction, recoil is always the main problem. Recoil, even though you use normal balloon and all that, it's always a problem. But with tri-wedge, I think it fares slightly better. Most of the time, you just use size 7 tri-wedge.
Okay, not size 6. I mean, according to the graft size.
No, I use size 7. Yeah.
Okay, all right.